So, viewers, good day to all of you. So, we are actually proceeding successfully with the lower limb. So, today I am here with one more new as well as a very important topic, that is the knee joint. Okay. Now, with respect to the knee joint, there is always basically what do you call, people tell or terrify that knee joint is a very vast topic. There are lot of structures, ligaments, and so many things. Of course, it is a bit elaborate topic, but the students, they need not worry about the knee joint. Now, I will be discussing this knee joint in two classes. So, first part I will be discussing in this class, and in the next class immediately I will continue with the knee joint. Now, not only that, at my second class I will also tell which aspects of the knee joint is very important and how it can be covered. So, we will proceed to the knee joint. In today's session, I am going to deal mainly with the introduction to knee joint, about the type, then the articulating surfaces, and then followed by the ligaments. So, today's class mainly I will be concentrating on the construction of the joint, how the knee joint is constructed. With respect to the movements, applied anatomy, blood supply and the nerve supply, we will be concentrating in the second part or the second half of the knee joint. So, directly we will move on to the knee joint. Now, basically, if you look at the knee joint, what type of a joint it is? Now, this can be compared to an elbow joint because it is of hinge variety, but only superficially, it is very superficial to tell that the knee joint is a hinge variety. It is a modified hinge variety, and of course it is a synovial joint. And why it is called as largest joint? Because it has got three articulations. One is, you all know that the femorotibial articulations. Again, that itself is divided by an intra-articular structure into two compartments. So, that is why we call it as a complex joint. Then we have the patella articulating with the femur separately, that is the patellofemoral articulation. Okay. So, it has got a patellofemoral and tibiofemoral articulations. So, that is why it is the largest joint, and all these articulations are present within a single joint cavity. Okay. So, complex is because again more than two bones are involved. So, apart from the femur and the tibia, patella is also involved. So, that is why. And because the interior of the joint cavity is divided by these intra-articular structures into two, the joint cavity is divided into two, you also call it as a compound joint, and it is a modified hinge variety. Now, it is a modified hinge variety means, first of all, the axis is not fixed. With respect to the flexion and extension of the knee joint, the axis keeps on shifting. That is one reason it can be called as a modified hinge joint. The second reason why it is called as a modified hinge joint is because apart from flexion and extension, there is also conjunct rotation taking place. So, conjunct means associated rotation taking place around a vertical axis. So, that means rotation in another axis. So, usually hinge joint, it is going to be only one axis, but here around a vertical axis, some amount of rotation actually takes place. So that is why it is also called as a modified hinge joint. So as I told you, the components are femorotibial. It is between the condyles of the femur and the condyles of the tibia. And then you have the femoropatellar. So the femorotibial component is again coming under the condylar variety of joint. So because the condyles are taking part in the articulation, it is called as condylar variety, whereas the femoropatellar component is cellar type. So convexo-concave surfaces, reciprocating cellar variety is also there between the femur and the patella. So these are all the things you can mention while writing about the type of the joint. So basically, when you describe it as one of the largest joint, synovial, modified hinge, complex compound, that will form a good introduction to the joint when you are actually writing in your answer sheet. So as I told you, all these bone articulation shares a single joint cavity. Okay. Now let us try to understand the articulating surfaces. So here you are able to see the femur, the articulating surface of the femur, which is actually shaded in green color, and of course you are able to see some red color. So that means the femoral condyles, you have the medial condyle of the femur and the lateral condyle of the femur. The two condyles you see here, they form the superior articulating surface. So which the anterior, the inferior and the posterior, the anterior, inferior and the posterior parts of the femoral condyles, they are responsible for the superior articulating surface of the medial and the lateral condyle. In between these two, you see this area is actually called as the intercondylar notch. Intercondylar notch. The anterior part or the anterior articulating surface of the femoral condyles, you are able to see that it is shaded in red because that is for the patella. So after both the femoral condyles, the anterior part, articulating part of the condyles anterior surface is for the patella, whereas the inferior and posterior parts are for the tibial condyles, for the femorotibial articulation, and this is more convex. Okay, so you are able to see that is more convex. And if you look at the patellar articulating surface also, over the lateral condyle, anterior surface, over the lateral condyle, patellar articulating surface, it is a bit extensive on the lateral surface. Okay, so the same thing you will also find when you see the articulating surface of the patella, that is the posterior surface of the patella articulates with the femur. Okay. So posterior and inferior surface for the tibial condyles, as I told you. Then this you are able to see the tibial condyles, the upper surface of the tibial condyles is articular, which forms the inferior articulating surface, and this is the raised area you are able to see intercondylar crest, and this is the intercondylar area you are able to see here, which gives attachment to so many structures from anterior to the posterior part. And this most anteriorly what you are able to see here is the tibial tuberosity. Okay, that is the tibial tuberosity. So this is actually the for the lateral condyles and for the medial condyle. Now when you look at the femoral condyles, again if you look at the lateral condyle, it is somewhat stout, massive as compared to the medial condyle. So because of that, what happens is the weight bearing in the knee is more towards the lateral condyle. So lateral condyle is mostly involved in the weight bearing. The medial condyle is somewhat long. Antero-posteriorly it is slender and extensive. Antero-posteriorly it is long, but transversely it is somewhat thinner as compared to the lateral condyle. Okay, so this is all for the purpose of the movement, effective flexion and extension of the knee, which we are going to discuss in the later part of this lecture. Okay, so anterior surface and for the patella, and posterior and inferior surface for the tibial condyles. So if you look at the articulating surface laterally, you are able to see that the lateral profile, it projects convexly downwards, and this is more pronounced inferiorly and posteriorly, the convexity. And what happens is, if you look at the lateral condyle, it accommodates the arcs of numerous circle. Okay, numerous circles, circle, it accommodates the arcs of numerous circle. And if you join the center of the each circle through a line, it forms a curved line through which flexion and extension takes place. So that means the condyles, what happens is, accommodates the arcs of a numerous circle. This is actually called as the evolute of profile. The same description of evolute of profile you can see in one more condyloid type of joint, your temporomandibular joint in the head and neck. That is also a condyloid variety. Okay, so through this evolute of profile, what happens is the axis shifts forwards and then backwards during flexion and extension. So that means during flexion and extension, the axis is shifting forwards and backwards through the arcs of numerous circle, and that is why I already mentioned that this joint is a modified hinge variety. Is that clear to you? Now you know what is evolute of profile. That is the evolute. Migrating axis of rotation is actually called as the evolute. Okay, so if you join all these arcs by a line, the transverse axis, as I told you, it is going to change. From flexion it moves forwards, and extension it moves backwards. The next you are able to see, as I told you, the lateral condyle, which I have described in my last slide itself. It is stout and massive for weight bearing. Now if you look the transversely orientation of these two condyles along a transverse line, then this is also lying on a horizontal line, the tibial condyles. But if you look at the long axis between the femoral condyle and tibial condyle, there is an angle of 170 degrees. It's slightly higher in case of males. The angle is actually open laterally. Okay, so the angle between the long axis of the femur and the angle between the long axis of the tibia, if you look where they meet here, they form an angle of 170 degrees to 175 degrees, which is open laterally. Okay. Now you see the bulge of the medial condyle, it is bulging more medially and gives attachment to the tibial collateral ligament, which is actually mentioned as cruciate ligament, medial cruciate ligament. So it differs, the terminology slightly differs from textbook to textbook. Okay, so we should get used to this terminology. Okay, so that is very important, very important. So only if you listen and read again and again, then naturally you will get used to various terminologies, which is very important, and it is the very basics of medicine. So many students, I hear requests from the many students to actually explain in Hindi. So I know you people are actually struggling a lot to actually get hold of these terminologies because it is in English. I will actually dedicate a separate session on this, why it is not possible to explain in Hindi. So when time permits, I will just what I will do is I will explain to you clearly why we should stick on to English. So let us not waste time on this session. We will directly move to the knee joint again. Okay. So the lateral condyle is not as much extending laterally as compared to the medial condyle, which is somewhat extending more medially and giving attachment to the tibial collateral ligament. Here it gives attachment to the fibular collateral ligament, the lateral epicondyle. Okay. Below the lateral epicondyle, you also see the groove for popliteus. So below this is actually your condyle. This is your epicondyle. Epi means upon, on top of the condyle. That is why it is actually called as the epicondyle. Anterior inferior part below the epicondyle, this area is for the popliteus muscle. But as you go posteriorly, it lodges the tendon of popliteus. It is grooved for the tendon of popliteus. Okay, laterally, below the lateral epicondyle, that area of the femur. Now coming to the intercondylar notch, which is actually present between the two condyles. This area is actually called as the intercondylar notch. To the medial aspect and to the lateral aspect, or vice versa, you can tell. To the lateral part of medial condyle, the anterior cruciate ligament is attached, and to the medial wall of the lateral condyle, the posterior cruciate ligament is attached. They are like crossing each other. That is why it is actually called as cruciate ligament. Are you able to understand? So where actually they are attached? They are attached to the intercondylar area. So laterally anterior cruciate ligament, medially posterior cruciate ligament. Okay. Or to put it in other words, we can tell anterior cruciate ligament is attached to the lateral part of the medial condyle, and the posterior cruciate ligament is attached to the medial part of the lateral condyle. Then you look at the tibial condyles. The upper surface is actually articular surface, and here you are able to see the medial and lateral condyles superior surface. They are very shallow, they are not very deep. Okay, and it is somewhat deepened by the intra-articular cartilage, that is the menisci, which is going to get attached to the peripheral margins. So 3/4 of the peripheral margins will be occupied by the medial meniscus and the lateral meniscus. Medial and lateral meniscus. They are not very deep. So this menisci to some extent increases the depth of the tibial condylar articulating surfaces because they are shallow. Something like we have seen our glenoid labrum, acetabular labrum, which increases the depth in the same way. Okay. So as I told you, deepened by the menisci, attached to the outer 3/4 periphery. I told you, the 3/4 of the peripheral margins is occupied by the attachments of the menisci. So lateral condyle is somewhat circular and small, whereas the medial condyle antero-posteriorly what happens is long, it's lengthened. And if you look at the lateral condyle, it will also extend a bit posteriorly. Okay, if you carefully examine in the tibia, this articular surface will be prolonged also to the posterior part to some extent, so that the tendon of popliteus is going to cross over there. So that is why it is related to the tendon of popliteus. Okay, then before that, this is the intercondylar area. You are able to see here. This actually you should know the attachments of structures. You have the anterior horn of medial meniscus, anterior cruciate ligament, anterior horn of lateral meniscus, posterior horn of lateral meniscus, posterior horn of medial meniscus, posterior cruciate ligament. So these attachments, if you know, then you can write the attachments for the medial meniscus and the cruciate ligament. So they are present in the intercondylar area. Now, very simple. If you look at the two horns of the lateral meniscus, they are present within the limits of the two horns of the medial meniscus. So after the anterior horn of lateral meniscus comes, and before the posterior horn of medial meniscus, the posterior horn of lateral meniscus. So both the horns of lateral meniscus are within the limits of the medial meniscus. Then anterior cruciate ligament is between the two anterior horns. Between the two anterior horns of the medial and lateral meniscus, you have the anterior cruciate ligament. But with respect to the posterior cruciate ligament, it is the posterior most structure. So it is posterior to all the other structures. Okay. So at the end, you have the posterior cruciate ligament and the intercondylar area. Next, coming to the medial condyle, as I told you, it is somewhat oval, long antero-posteriorly. In the last slide itself, I have shown you it is got a long antero-posterior, same like your medial condyle of the femur, which is also slender and long antero-posteriorly, whereas the lateral condyle is somewhat stout. Okay. Then, if you look at the combined menisco-tibial compartment, so that is the menisci with the tibial condyles put together, it is actually called as the combined menisco-tibial, because this is menisci, this tibial, this is called as menisco-tibial, this is menisco-femoral. This is menisco-femoral. So the joint cavity is divided by this menisci into menisco-femoral and menisco-tibial. So the upper compartment will provide rotary movements. The lower compartment mainly will provide gliding movements. Okay. So gliding movements takes place in the menisco-tibial compartment. If you look at the combined lateral menisco-tibial compartment, is comparatively deeper than the medial one, because it has to accommodate this massive lateral condyle of the femur. Okay. So there is no perfect congruency between the tibial and femoral articular surfaces, like your cup, acetabular cup and the head of the femur. No, it is somewhat fitting, more congruent. Here you are able to see more projecting and convex femoral condyles, but the tibial condyles are somewhat shallow and only deepened to some extent. So that means when there is incongruency, means maximal contact is not reached. Okay, they don't contact very well maximally. Okay, so not exactly opposed surface. Okay, so maximal contact is not expected all the times. So that is why you are calling it as non-congruent. So you have seen about the tibial condyles, we have seen about the femoral condyles. Now I am going to, or we are going to discuss about the patella. You all know that patella is a sesamoid bone, the largest sesamoid bone in the body. It is developed within the tendon of the quadriceps femoris. Okay, it is developed within the tendon of quadriceps femoris. You are able to see the anterior surface and you are able to see the posterior surface. This is the base and this is actually the apex. Apex. What is attached to the apex of the patella is the ligamentum patellae. Okay. If you look at the articular surface of patella, the posterior surface is actually articular, but the apex even on the posterior surface is non-articular, for which it gives attachment to the ligamentum patellae. If you look at the articular surface, it is divided by a vertical ridge into a large lateral area and a small medial area. Large lateral area and a small medial area. So based on this, you can decide the side of the patella very easily. When you see the large extensive lateral surface which is being to the lateral side, it belongs to that side of the patella. Okay. Then the medial surface, again you see one more vertical ridge. You have a semilunar articulating surface more medially. Okay, semilunar articulating surface more medially. Okay, now this articulating surface, medial or lateral, lateral is more extensive, will be again divided by faint transverse ridges into three pairs of facets. Above pair 1 2, then in between a pair of facets, and again lower part again a pair of facets. Okay, so as I told you, there is one more narrow strip here. Now upper articular is, it will contact with the femur during normal flexion. This strip semilunar area comes in contact with the femur during full flexion. Okay, so this is during normal flexion, this is during full flexion. The middle area is during semi-flexed. Okay, when the semi-flexed position, the middle articular area comes in contact, and during normal extension or ordinary extension, the lower articular areas come. During your normal walking process, you extend and flex the knee. Okay, but when you completely extend in full extension, the patella does not make any contact with the femur. Okay, so the patella is free. Are you able to understand? During full extension, you can see when you are standing upright, you can see the kneecap which can move medially and laterally. Okay, in extension it moves laterally, not frequently fractured. If at all it is fractured, since there is no periosteum, reunion of the bone is not possible. Okay, only if the periosteum is there, it will supply the osteoblasts, osteoprogenitor cells, osteoblast for the growth of the bone. But here no periosteum, so naturally once if it is fractured, what happens is it is difficult. Okay, so what happens is lateral vastus lateralis and vastus medialis are all attached through the quadriceps tendon. The vastus medialis, what happens is, pulls the patella from lateral displacement to some extent. Okay, prevents the lateral displacement. That is one thing. What is the function of patella? It minimizes the friction. During full extension, it is actually present between the femoral condyles and the tibial condyles. In extension, what happens is, it increases the momentum of the quadriceps tendon. So basically in extension, in full extension especially, it increases the power of the quadriceps tendon. That is the main function of the patella. Okay, so far we have discussed about the articulating surfaces of the knee joint. So by now you should have a very fair idea about the nature of the articulating surfaces. Now we will move on to the ligaments of the knee joint. So first we will try to list out the ligaments. Capsule, then you have the, of course, within the capsule we are also going to discuss about the synovial membrane, followed by ligamentum patellae. Then you have tibial and fibular collateral ligaments. You have oblique popliteal and arcuate popliteal ligaments. Then you have cruciate ligaments, anterior and posterior. Then coronary, transverse and meniscofemoral ligaments. Then medial and lateral menisci. Okay, so seeing the number of ligaments, again you might get worried. So many ligaments for knee joint, should I have to memorize all these ligaments? Not necessarily. It is very simple to, if you understand, then naturally you can recall it very easily. No need to memorize. So without understanding, if you simply try to memorize or mug or by heart, definitely you tend to forget. Okay, Now before that I will tell you, you should concentrate of these certain ligaments are very important. That is the anterior and posterior cruciate ligament. First you should read this. You should know very well about this. Then medial and lateral menisci. Okay. Then next oblique popliteal ligament. So these three ligaments are very very important. You should know about the cruciate ligament, menisci and oblique popliteal ligaments. Okay. You should concentrate much on these three ligaments. I am not telling that you should not read the other ligaments, but these three ligaments you should be thorough, and other ligaments you should have a fair or general idea about how they are disposed and what support they give to the knee joint. So you are able to see this is a diagram of a knee joint with a capsule open. You are able to see the knee joint cavity inside, and of course you are able to also see the tibial condyles, the femoral condyles and the knee joint cavity. Now what are the attachments of the capsule? It is attached to the margins of the superior articular margins and the inferior articular margins. Let us not go much into details of these attachments. Okay. So, and then in the front there is an opening in the capsule. You have a large opening above the patella for the suprapatellar bursa. Here it is given as suprapatellar pouch, through which the capsule has an opening. A deficiency in the capsule is present. Same way, behind the lateral condyle you have an opening for the tendon of popliteus muscle. So the capsule has two openings through which it communicates. Okay, one is the suprapatellar bursa, deficient for the suprapatellar bursa, and other one is for the tendon of popliteus. Okay. Then the capsule is actually strengthened medially by the tibial collateral ligament, posteriorly by the oblique popliteal ligament, laterally it is actually strengthened not by the fibular collateral ligament, because there is a gap between the fibular collateral ligament and the capsule, and the tendon of popliteus is going to come there. So it will be strengthened mainly by your iliotibial tract laterally. Laterally the capsule is strengthened by iliotibial tract. Okay. The capsule in front is actually strengthened by the ligamentum patellae. So posteriorly you are able to see the oblique popliteal ligament is merging with the capsule. Okay. You see fibular collateral ligament, there is a small bursa, and the tendon of popliteus is also going to intervene between that. So it does not merge with the capsule, whereas fibular collateral ligament merges and strengthens the capsule medially. Posteriorly the oblique popliteal ligament, anteriorly the capsule merges with the ligamentum patellae, and laterally, as I told you, the iliotibial tract, modification of deep fascia, which I have seen in the earlier classes of the lower limb. Okay. Then to the interior of the capsule, even the menisci gets attached. So we will see menisci after a few slides. One by one we are going to see. So that is about the capsule, attached mainly to the periphery of the articular margins, and it has two openings, one for the suprapatellar bursa antero-superiorly, and behind the lateral condyle for the tendon of popliteus. Okay. Synovial membrane. So if you look at the synovial membrane, it again lines the interior of the capsule but does not line the articulating surfaces. Articulating surface will be covered by the hyaline cartilage, and definitely the synovial membrane ceases at the margins of the articular cartilage. Okay, because beyond that, if the synovial membrane is there, definitely it will get damaged when the two bones come to contact with each other. Okay, so that is one thing. Then when you look at it, the capsule above sends an extension of a pouch to the deficiency in the capsule, that is for the suprapatellar bursa. So continues with the suprapatellar bursa, and that is held in its position by a muscle, that is the articularis genu muscle. The suprapatellar bursa is prevented from getting stuck inside the joint between the bones by the prevent from moving by the articularis genu muscle, held in position by the articularis genu muscle. Then you also have a infrapatellar fold of synovial membrane. Infrapatellar fold of synovial membrane. Okay. Now primitive, if you look at the primitive joint cavity, okay, this is actually divided into two compartments by the intercondylar septum. Okay, you have the intercondylar septum, and there is a foramen between the intercondylar septum, thereby the two separate cavities. The lateral femorotibial compartment and the medial femorotibial compartment is separated by intracondylar septum, and there is a foramen, thereby dividing the septum into an anterior part and the posterior part. The anterior part and posterior part, the posterior part, the primitive intercondylar septum only gives rise to your cruciate ligament, and now the synovial membrane lines the sides of this cruciate ligament. Okay. Anteriorly, it has got the infrapatellar fold. The apex is attached to the patella and the base projects like this posteriorly. It projects posteriorly, and the lateral free margin of the infrapatellar fold, which is present between the gap between the menisci and the tibia, and they form the alar folds. Ala means wing-like. Okay. So like wing-like from the infrapatellar fold, like a semilunar space in between this joint cavity, laterally it extends as the alar fold. What extends? The infrapatellar fold. The infrapatellar fold represents the anterior intercondylar septum. Posterior intercondylar septum is actually now represented by the cruciate ligaments, and naturally there is a foramen between the anterior and the posterior part, the intercondylar foramen. Okay. So cul-de-sac from the posterior part of the capsule extends as the synovial membrane, forms a partition between the condyles, and the synovial membrane lines the sides of the cruciate, then interior of the capsule, but ceases at the level of the articular margins and continues above with the suprapatellar bursa. So that is about the synovial membrane. The next to the capsule, now we are dealing about the ligamentum patellae. So you are able to see this is actually the quadriceps tendon. The ligamentum patellae extends from the apex of the patella to the tibial tuberosity. So develops from the tendon of quadriceps femoris, as I told you, from the apex of the patella to the tuberosity of the tibia. Near the apex you have the infrapatellar bursa, then you also have suprapatellar bursa. Okay. So again, bursa around the knee joint we are going to see in the later stages of this lecture. So this tendon is not taut, means it is not stretched or very tight during full extension. Okay. As I told you, patella does not make any contact with the femur. It is not taut in the full extension, but during normal extension what happens, this ligament is stretched. But when you are completely standing upright with full or complete extension, what happens is this ligament is relaxed, the ligamentum patellae. The next ligament you are able to see is the tibial collateral ligament, extending from the medial epicondyle of the femur to the medial condyle of the tibia, and it has got a superficial and a deep part. It has got a superficial part and a deep part. It is the modification of adductor magnus. So above the medial condyle, epicondyle, you have adductor tubercle, up to which the adductor magnus extends, but below that it is the degenerated tendon of the adductor magnus, the tibial collateral ligament, which strengthens the capsule medially. As I told you, it has got superficial and deep part. So attached to the medial epicondyle of the femur, superficial part to the tibia, medial condyle and shaft, deep part blends with the capsule and medial menisci. So this is the medial meniscus you are able to see. Between the superficial and deep parts, you can see infromedial genicular vessels and some part of semimembranosus muscle also is present between the superficial and deep parts of the tibial collateral ligament. Okay, so semimembranosus muscle and the infromedial genicular vessels can be seen. The next ligament you are able to see is the fibular collateral ligament. So fibular collateral ligament is again attached to the fibula. So upper part of fibula, only two ligaments are attached. One is actually the fibular collateral ligament. It is the primitive attachment of the peroneus longus muscle. Okay, so peroneus longus, original attachment is here, but now what happens, during its course of evolution it has moved to the fibula, lower downwards. Peroneus longus is actually a muscle of the lateral compartment of the leg. So primitive origin of the peroneus longus tendon extends from the lateral epicondyle of femur to the head of the fibula and passes deep to the biceps femoris. Does not merge with the capsule. Between the capsule and this one there is actually a bursa, and also the tendon of popliteus is passing between it. So as I told you, you can see the tendon of popliteus and infrolateral genicular vessels passes between the fibular collateral ligament and the capsule of the knee joint. So that is about the fibular collateral ligament. So we have seen about the capsule, we have discussed about the ligamentum patellae, then we have discussed about the tibial collateral ligament and the fibular collateral ligament. Next, oblique popliteal ligament. So tibial collateral ligament, adductor magnus tendon modification. Fibular collateral ligament, peroneus longus tendons, primitive origin. Oblique popliteal ligament is again an extension from the semimembranosus. Okay, so extended expansion. The tendon of semimembranosus is attaching to the medial condyle of the tibia. From there, posteriorly, laterally. Okay, so posteriorly it extends above and laterally as the oblique popliteal ligament. From the posterior surface of medial condyle, it is actually going to the lateral part of intercondylar area of femur. It strengthens the capsule posteriorly. So merges with the capsule and strengthens the capsule posteriorly, and in the middle you can see it is pierced by the middle genicular vessels and also genicular branch of the obturator nerve. Okay, it is pierced mainly by the middle genicular vessels and the genicular branch of obturator nerve. So that is about the oblique popliteal ligament, which is an expansion from the semimembranous. So you can see three ligaments which are actually some or other type of modification of these three muscles. Next, you are able to see is the arcuate popliteal ligament. It is somewhat Y-shaped. It has a stem and it has got an anterior and a posterior limb. So the next ligament, I told you fibula, two ligaments gets attached. One is the fibular collateral ligament, and here you are able to see the fibular collateral. Another one is the arcuate popliteal ligament. So attached to the styloid process of the fibula stem. Then what happens is anterior band to the lateral condyle of the tibia and the posterior band to the lateral condyle of the femur. So this goes to the tibia and this actually goes to the femur. Two bands. Y-shaped ligament, arcuate ligament, or you can also call it as arcuate popliteal ligament. Then you come across some coronary ligaments and transverse ligaments. So coronary ligament are nothing but the lateral thickenings of the capsule which gives attachment inner part. The menisci comes and attaches. So that is why a little bit fibers of the capsule are thickened there, which is actually called as the coronary ligaments. Transverse ligament you are able to see here. This is actually the transverse ligament. Connects the anterior horns of the menisci. So this is the lateral menisci, this is the medial menisci. The two anterior horns of the menisci are actually bridged across anteriorly, by some fibers which is actually called as the transverse ligament. Then you have the meniscofemoral ligament. You have the meniscofemoral ligament. It has got an anterior part which is called as Humphrey and posterior part which is actually called as Rosberg. Anterior part Humphrey and posterior part is Rosberg. So here you are able to see here. So what happens is from the posterior horn of the lateral meniscus, some fibers go beyond the posterior cruciate ligament, and that part is actually the Rosberg. Some fibers go in front of the posterior cruciate ligament, that is actually called as the Humphrey. Okay, so connects the posterior horn of lateral meniscus to the medial condyle of tibia. So it is actually some fibers which is connecting the lateral meniscus, which are able to see here to the medial condyle, and it passes in front and behind the posterior cruciate ligament which is called as Humphrey and Rosberg. Transverse ligament, coronary ligaments, and then the meniscofemoral ligament which has got a anterior component of Humphrey and posterior part of Rosberg. Yes. Now we are coming to the cruciate ligaments, very, very important. Now these structures, cruciate ligament, menisci, cruciate ligament, menisci, tendon of popliteus, these are all called as intracapsular but extrasynovial structures. That means they are present inside the capsule but outside the synovial cavity. Okay, only the cruciate and menisci are lined by synovial membrane. So deep to that membrane you have the synovial cavity. So it is not within the synovial cavity, extrasynovial but intracapsular structures. So if they ask directly about cruciate ligament, you can discuss about the cruciate ligament. Or if they ask about the menisci, you can describe about the menisci, or indirectly they can ask simply discuss about the intracapsular extrasynovial structures of the knee joint. Then again you have to write about your cruciate and menisci mainly, and you can add to some extent the popliteus muscle origin. So as I told you, it's an intracapsular extrasynovial structure developed from primitive intercondylar septum. That's what I told you. The posterior part has evolved into this cruciate ligaments, anterior and posterior cruciate ligament. So anterior cruciate ligament from the intercondylar area, you are able to see here between the two anterior horns, and it goes and gets attached to the medial surface of the lateral condyle. Medial surface of the lateral condyle, or you can simply tell it as the lateral wall of the intercondylar area of femur. Anterior cruciate ligament. So it is very tight during extension. Okay, during extension what happens is it is tight, and it is also going to provide as an axis around which the femur is going to rotate during the last or later stages of extension, or vice versa during the beginning stages of flexion. Okay, that is about the anterior cruciate ligament. It prevents the forward displacement of the tibia. So tibia from dislocating forward, or at the same time it prevents the backward displacement of femur. So it is, see how it is holding. It is actually pulling the femur front so that it doesn't get displaced backwards. Anterior cruciate ligament. The next ligament which we are going to see is the posterior cruciate ligament, which you are able to see here. So arises from the posterior most part of the intercondylar area of tibia, and it is going to go to the lateral surface of medial condyle. So it is going to the lateral surface of the medial condyle of the femur, that is the posterior cruciate ligament. It is very tight during flexion and extends upwards, forwards and medially. So it is actually traveling, extending upwards, forwards and medially. Like this it is coming. Prevents backward displacement of tibia or forward displacement of the femur. Okay, forward displacement of the femur. Now The anterior cruciate ligament is there, the posterior cruciate ligament is there. Of these two, which is very important, whether the anterior or the posterior? You might think anterior cruciate ligament is very tight during extension, and of course the posterior cruciate ligament is actually taut or stretched during the flexion. Posterior cruciate ligament is comparatively important than the anterior cruciate ligament. Why? Because very simple, when you are actually descending down the steps, suppose you are descending, coming down through the steps, you can feel this when you climb steps in a mountain. No, we need temples which are above a mountain. When you climb up and when you come down, what happens is when you descend, the leg which you put downwards, the whole that knee bears your weight, and what happens is the center of gravity is also present forwards. So you tend to be pushed forwards, and there is forward displacement of the knee is possible. So that is actually prevented by this posterior cruciate ligament. The whole weight of your body which is falling on the knee is actually borne, the brunt is actually borne by the posterior cruciate ligament, especially when you are descending, climbing down the stairs, not climbing up the stairs. Okay, your center of gravity and your weight bearing, everything tends to push you downwards. So the stability when you descend downwards step by step, it is actually the function of the posterior cruciate ligament is inevitable. And they also prevent, because they are in crossed manner, this is pulling and this is pulling this way, side to side displacement is also prevented. And as I told you, this anterior cruciate ligament serves as an axis for femoral rotation during the last stages of extension or during the initial stages of flexion. So that we will see during the movements. So next important ligament after or next to the cruciate ligament, we are going to discuss about the menisci. So if you look at the menisci, you are able to see here two menisci are there, intra-articular structures. They are also intracapsular, extra-synovial, divides the joint cavity into two, upper meniscofemoral and below meniscotibial compartment. It actually deepens to some extent the shallow tibial condyles, articular area of the tibial condyles. They are made up of fibrocartilage, not hyaline cartilage, semilunar, moon shape. That is why intracapsular, and as I told you, not lined by synovial membrane. The periphery merges with the capsule, the interior of the capsule. Okay. So medial meniscus, if you look at it, it is somewhat semilunar, longer antero-posteriorly. The anterior horn is somewhat thin or pointed as compared to the posterior horn, anterior horn and posterior horn of the medial meniscus. Okay, anterior horn is somewhat narrower. So medial margin of this is attached to the capsule and also merges with the tibial collateral ligament. The lateral margin is free. Upper surface is concave, lower surface is flat. The under surface of the cartilage which is touching the tibial condyle is actually flat. Next, coming to the lateral meniscus, almost a circle, 4/5 of a circle, not semilunar like this, crescent shape, not crescent shape, almost like a circle. So the meniscofemoral fibers we are able to see here to the lateral meniscus. We have seen that ligament, Humphrey and Wisberg, and few fibers of the popliteus muscle is also attached posteriorly to the lateral meniscus. This is your transverse ligament, posteriorly the meniscofemoral ligament you can see. So popliteus actually pulls the menisci backward during flexion, and meniscofemoral regulate forward gliding during extension. So this meniscofemoral, they regulate the forward gliding of the lateral meniscus during extension. And as I told you, if you look at the lateral meniscus, the articulating surface of the tibia is somewhat extending backwards for the lateral condyle with respect to the lateral condyle. So there this meniscus and the popliteus muscle will come and articulate over this area. So it is grooved for the tendon of popliteus and the medial margin is free. There it is, the lateral margin is free and medial margin merges with the capsule and the tibial collateral ligament with respect to the medial menisci. So menisci, semilunar cartilages, divides the joint cavity. Above surface, upper surface is concave, lower surface is flat. Lateral meniscus and medial meniscus. Medial meniscus is somewhat semilunar with narrow anterior horn. The lateral meniscus forms the 4/5 of a circle. Functions: depth of the tibial condyles, we have already seen that. Spread of synovial fluid evenly to the articular cartilages, and definitely it acts as a shock absorber. Fibrocartilage, cartilage of wear and tear. Upper compartments, as I told you, rolling and spinning and rotary movements. Lower compartment, meniscotibial compartment, permits mainly your gliding movements. Okay, so that is about the menisci. Meniscal tear is also more common in sports person, again which we are going to discuss in the applied anatomy of this knee joint in the next session. So peripheral part receives blood supply directly, but the inner parts has to receive its nutrition only from the synovial fluid, diffusion from the synovial fluid. So in today's class I have discussed about the articulating surfaces, then the ligaments of the knee joint of this cruciate and menisci is very very important. You should know the attachments, the functions of the cruciate and the menisci because they are the intracapsular and extra synovial structures. So thank you. We will meet again in the knee joint with the remaining aspects.